Good. I think
Thank you.
sometimes that people have a misunderstanding of what my purpose is and what my goal is because I can be so outspoken. I often get that initial reaction. But as I said, I'm hoping for really nuanced, reasonable discussion today. We can ask difficult questions. We can say where we don't know, because I think both of us are certainly, as you said, coming on here. We're on the same team, and we care about people, and that's what we're trying to do. We're trying to improve the lives of others. But you reached out to me, so let me just start with that. I was interested in what motivated you to come on the Radically Genuine podcast, and then if you can just tell my listening audience a little bit about you and your background.
Mhm. Well, I guess I first became aware of some of the critiques and commentary on psychiatry through Will Hall, who was on Psychedelics Today. I think 3 years ago, they did a two-part interview with him. And he laid out a whole bunch of critiques about psychiatry, which got me sort of riled up. But I also thought, I agree with some of this. So since then, I've started just kind of keeping my eye on and ear on what are people saying about psychiatry, because it's I've devoted my life to it and I believe in it, and I also believe it has a ton of flaws and problems, and we're struggling through the muck for sure. But in my experience, most of the psychiatry critics are not mental health experts. And then I stumbled upon your podcast and I thought, this guy's smart. He's well spoken. He's a psychologist. And as I told you before we started recording, I have to admit I have a huge bias towards psychologists. I actually love some of my most favorite people are psychologists. So I liked you already from that. But then when I listened to a couple of your episodes, I thought, I really want to talk to him. I don't want to argue or yell or debate or win, or I want to just sit down and have a conversation, because I think there's so many things that we agree on. I think there's things we don't agree on, and that might be really interesting for people to hear today. Not that I'm going to convince you or you're going to convince me, but just that there can be two well-educated professionals on the mental health field who maybe don't agree on all the tactics, but that we can talk about it and we can have a reasonable discussion and just try to understand where we come from.
Love it. Now you're a little bit outside what we see in at least my region as typical psychiatry. I mean, I think you're aware that it's kind of transitioned itself into DSM diagnoses and handing out prescriptions fairly quickly, monitoring meds, and then often adding more and more prescriptions, shifting diagnoses, and so forth. The outcomes are, astonishingly poor in um, a lot of like research trials and what we see in community-based settings. We don't see really like strong recovery rates. We do see some, symptom reduction or modification in certain conditions, but all available evidence to us suggests we had a long way to go and people need to be more informed. I want to just get a sense of your journey in this and where you are now.
Yeah, well, I think my interest in this area, in sort of psychiatry, what is it? What do we do? I mean, really started in residency, and I went to a residency that celebrated therapy. We had, we learned psychopharmacology and medical diagnostics, but we spent a ton of time doing therapy, and therapy was celebrated. And I remember the first letter to the editor I ever wrote to a psychiatric journal was about this whole idea of psychiatrists calling themselves psychopharmacologists. And
Mm.
and I wrote, and this is back, like in, when was like 2002, and I wrote the journal. I said, this is a terrible idea. This is a terrible idea for people to think of themselves as psychopharmacologists, for people to use that term, because it would be like if landscape architects started saying, you know what, we are soil managers, or if general contractors said, we're going to be toilet mechanics. It's like, wait, why limit the beauty and the complexity down to just medicine? So that said, I think medicines can be game changing, and I think that's a place that maybe you and I don't agree. But this whole idea of med management I think is insane. And it's one of the things I talk about a lot in my podcast. I try to give examples of people healing. There's no healing through med management on the podcast. I mean, there are people who heal with meds as part of the picture, but one of the things I'm trying to paint is that, I often tell my patients, like, if this is the jigsaw puzzle of your treatment, maybe these two pieces up here are your meds, and this is your sleep, and this is your weed addiction, and this is your relationship, and this is your exercise, and this is your diet, and it's all part of it. And we're going to talk about all of it. But this whole idea that in psychiatry that you can manage psychiatric illness with meds primarily is largely insane.
Well, yeah, let's start with I was listening to a very interesting podcast you had with one of your colleagues who I think was part of outside of Boulder. I can't recall his name,
Will
but
Vanderveer.
yeah,
Yeah,
I
yeah.
thought it was a great podcast. I mean, I found that one fascinating. And I think you opened it up by asking, what is wrong with psychiatry? And is it Will? Will said, well, it starts with basically it's the diagnostic system and the treatments,
Yeah,
generally
yeah.
speaking. So what are you critical of when it comes to your field as far as the diagnostic system and its conventional treatments?
Yeah. Well, as I said to Will, I was joking, but I wasn't really joking. I said in that episode, I said to Will, I said, I think the DSM could really just have maybe 5 diagnoses, maybe 6. And it would be the state of the art, what we understand about the brain and mental and psychiatric illness now, to have 5 or 6 diagnoses. And the splitting to come up with all these BS diagnoses like intermittent explosive disorder, social anxiety disorder, it's all fake. Like, I mean, they're a real pain, but they mean nothing, you know. And even, we'll probably get into this, but I think one of the things that a lot of people don't understand is in the whole placebo antidepressant thing is that psychiatry not only has a huge classification problem, understanding, we have a huge naming problem.
Yeah.
So, and I did an episode on this. I don't know if you heard it, but I did an episode on how all the names we use in psychiatry are wrong. So the meds that we call antidepressants, SSRIs, mostly don't work for depression. The meds we call mood stabilizers mostly don't stabilize mood. The very best antidepressants are the atypical antipsychotics, which actually are very poor antipsychotics. And the very best mood stabilizer by far is an antipsychotic. So, and I could go on, but so we have this whole confusion where we talk about things like as if antidepressants were a thing or MDD were a thing, but everything is just mushy and it doesn't even mean what we think it means. So there's a psychiatry podcast called the Carlat Report, which I like a lot. And I've written him a few times because he's always talking about antidepressants this, antidepressants that. And I say, what are you talking about? Like, what does that mean? Like, do you mean SSRIs? Because I've said, those are not really antidepressants. He said, yeah, but that's what the general population thinks. I said, well, we need to be good with our words and not just throw out these meaningless titles.
Yeah, don't you think that there's a major problem with credibility in your field is when you misrepresent what you're able to do by calling it antidepressant? Now it's gone and extended way beyond just psychiatry. We have like over 80% of antidepressants are being prescribed by primary care doctors. But when we talk about informed consent and people being able to be informed about the healthcare decisions that they're making, they are taking these drugs under the assumption that they will have antidepressant qualities, and most of them are not provided the legitimate harms. Like I've real concern about emotional blunting and numbing, and its potential long-term consequences on sexual functioning, for example. And we're certainly seeing a number of cases that are implicated in self-injury, suicide, and violence. So your field has failed to adequately be able to communicate the legitimate dangers and then overvalues the benefits through language by using words like antidepressant, which is in alignment with the pharmaceutical industry. And it's created, unfortunately, indelible harm. There's been withdrawal. People have hooked on these drugs, can't get off of it. We don't have good, adequate data on the long-term consequences. But here we are. It still continues today. And that's where there's a credibility issue.
Mm-hmm. Yeah, I'm still shocked and crushed at how many physicians think that SSRIs are antidepressants. I'm like, these are for anxiety. Yeah, they work for a couple types of very specific types of depression, but in general, no, they aren't antidepressants. They are anti-rumination, anti-panic, anti-anxiety meds. So like the patients are confused, the doctors are confused, everybody's confused, and a lot of times I've had patients, this happens all the time where people will come to me and they'll, come in with horrific depression. And they'll say, well, Dr. Heacock, my therapist said I should go on an antidepressant. I'm like, you are on 2 antidepressants, but they might be on like clozapine and lamotrigine, which is an antipsychotic and a mood stabilizer. But really those are actually meds that can powerfully help with suicidal depression, but nobody thinks of them that way. So that's a thing I've tried to put out on Back from the Abyss for patients and families and docs and therapists to help them think about I mean, even just the labels are so confusing. And then, I think you bring up a really good point about informed consent. And this is something nobody talks about. I'll just put it out there. I haven't heard you talk about it, but I think where informed consent gets really sketchy is with severely mentally ill. Because, we have people, treatment-resistant schizophrenia, who are probably not able to make good medical decisions for themselves. And, I regularly do this. I might say, I want you on clozapine. I might say this has a white blood cell issue, but do we go into all the potentially scary side effects of some of these really serious meds with the very mentally ill? We don't, because it's so hard to get them to take the meds anyway, especially the people with chronic psychosis. And that's kind of a hush secret in psychiatry, is that the sickest people get the least informed consent. I don't know how that would change, because again, I treat a lot of these people like a lot of folks, who would come in my office and say, I don't have any illness. Meanwhile, they just got out of jail, or they just tried to cut their penis off, or they just ran naked in the woods and were found by EMS, with hypothermia. So yeah, I agree. Informed consent is complicated. Even just telling people, what I tell people with SSRIs is, you're very likely going to have orgasm problems. And that's, people giggle and laugh like, oh, you're like, oh, that's uncomfortable. I'm like, no, like we do this med, it's going to be hard for you to come. Like that's very likely. And I've had many people say, no one's ever told me that. Or people come to me on a bunch of SSRI trials and say, nobody's talked about orgasm. And I say that we're going to talk about orgasm. And when I have med students and Psych and Ps rotate with me, I say, always in the first session, first evaluation, we're going to talk about sexuality. I want you to ask about orgasm, because I want people to realize, because that is a huge issue with psych meds, sexual functioning. And